Good morning. It is Tuesday, October 19th. Welcome into the Morning Medical Update. We are live here inside the Dolph Simons Family Broadcast Studio. Thanks to everyone for joining us on Facebook and also YouTube this morning. We are glad you are here. The C word. It is something no one wants to hear. You have cancer. It is tough to digest, but one mother and daughter duo, they faced it together. Also, the help of our comprehensive cancer programs right here at the University of Kansas Cancer Center help them find their way back to better health. And we're going to hear more of their story. But first, let's get straight to our numbers from overnight. Dr. Hawkinson, good morning to you.
Yeah, hi.
Hi.
So our numbers are ticking up just a little bit. You know, we certainly hope they stay in that 15 to 20 range right now. 20 active infections with 7 in the ICU and 2 on the ventilator, and 31 in that recovery period. Obviously, less active infections is better, and hopefully we can continue the overall downtrend that we have seen the last 2 or 3 weeks.
Hayes numbers?
We don't have those.
Okay, we'll get them if we get them in. All right, do we have reporters on the line?
Sure. Good morning. Cody Holyoke with Channel 9.
Hey, good morning, Cody.
Hey, good morning. Quick question for Doc Hawk here. We're starting to see these masking rules in local cities and towns, counties, start to go by the wayside, or at least conversations about that as new coronavirus case numbers tick down. Prairie Village last night voted to let their mask rules expire at the end of the month. It's the writing's on the wall probably for some of the other cities and towns and counties. I'm curious, just from a medical standpoint, any advice to cities that are considering doing this to let these expire, or to people just wondering if taking masks off is a good idea as we get into the fall?
Yeah, I mean, we are getting into colder weather. More people are going to be going inside to doing things. I think medically and from the public health standpoint, we know this increases the risk. We know it increases the risk of spreading it to people. We know it increases the risk of spreading it to those people that are most vulnerable as well. And the other caveat to this is we know that there continues to be a large number of eligible people who are unvaccinated, and so that will help the spread as well. So from the medical and public health standpoint, it certainly does increase the risk of continuing to have a higher prevalence of case numbers and thereby have a high number of hospitalizations and death as well. The main thing to this is we have to continue to endorse that message, give that message that if you are eligible or your children are eligible, 12 and over, anybody 12 and over really should be vaccinated. And it's not just about you, your individual, but the other people around you as well. When we saw that play out with Colin Powell, some healthy 25-year-old or 30-year-old may do very well with this virus, even without the vaccination. However, this virus can spread to those that are most vulnerable, and so really getting vaccination does continue to help decrease the spread as well.
Other questions on the line today?
Hi, it's Taylor at Channel 41. Good morning.
Hey, good morning.
Hi.
I apologize if I'm the 15th person to ask you this question this week, but I haven't had a chance to ask you yet. Talking about mixing and matching booster shots versus vaccines, can you just talk about the science a little bit? Because obviously, take Pfizer and Moderna that are mRNA vaccines versus the viral vector and Johnson & Johnson. Is there a difference inside your body when you've used one than to use a different one potentially as far as how the vaccine is delivered?
Yeah, the best evidence we have is from England, where they looked at the AstraZeneca vaccine, which is similar to the Johnson & Johnson, and they paired it with the second dose because AstraZeneca is a 2-dose series, but their second dose they paired it with Pfizer, and it did show very good, robust immune responses both in T cells as well as B cells, and B cells are what make antibody. T cells are the other component. So there is good published data on that. What exactly does that mean clinically? It's really hard to say. I know that I saw a headline today that the FDA will recommend or okay mixed dosing be used. So mixed dosing meaning not necessarily different companies such as Moderna and Pfizer, although that could be, but different platforms such as the Johnson & Johnson adenovirus vector platform plus the mRNA. So there is good, sufficient data showing that they both do, whether it's using the regular dosing or the mixed dosing, they do give good immune responses both in the B cells and T cells. What exactly does that mean clinically? It's hard to say. I think we need to continue to promote people who aren't vaccinated to go out and get those first series, whether it's the first Johnson & Johnson or those first 2 mRNA vaccine series. So, but what I did see is that they will be allowing or okaying the people that are able to get mixed dosing. How much of an impact will that have clinically and protect you better? It's really hard to say at this point. But again, we want everybody who hasn't even gotten any doses of vaccine to get vaccine doses. But I believe probably there will be more information about that mixed dosing coming out soon, just as it was only today that FDA announced that they would eventually okay that mixed dosing regimen, whether you get Johnson & Johnson and then you get an mRNA vaccine for that second dose, or if you've had the mRNA vaccines and get Johnson & Johnson. It's hard to say what exactly will be recommended, but the FDA is at least okaying that moving forward.
Other questions today? All right, we are good to go. We're going to get to our topic. It is Breast Cancer Awareness Month, so we are hitting it pretty hard this month, so get your questions in. As many as 10% of all cases of breast cancer are hereditary, and that's according to the CDC. Hereditary cancer could be caused by a change in certain genes you inherited from your mother or your father. And for one mother and daughter, it's something they know all too well. Both are breast cancer survivors. They both credit the University of Kansas Cancer Center survivorship and high-risk programs for making it happen. As Petrania Poonswan reports, both women want people to know you can beat this and take back your life.
Libby Sinovic and her mother, Kathy Ritz, share many things: a love for travel, books, and wine. Now they share this. Both are breast cancer survivors.
My mom was diagnosed with breast cancer like 20 years ago. We always knew as I got older that I would have to start mammograms and preventative screening earlier.
Diligent screening eventually lead to the family history Libby feared most. Just 3 months after her wedding, Dr. Lauren Nye, breast oncologist at the University of Kansas Cancer Center, diagnosed Libby with stage 1 breast cancer, and then diagnosed breast cancer again in her mother, Kathy, on her 60th birthday.
That news initially is really hard to digest, but then as you start to learn more, I think we ultimately did feel so lucky in a sense that I did catch it so early.
Both say the early diagnosis may have been missed if it weren't for the Cancer Center Survivorship Program and Libby receiving preventative care.
If it weren't for that program, she wouldn't have had mammograms yet, or maybe just a mammogram. But what caught it was the ultrasound. Same with mine. The program to me has just been,
Life-saving.
Yeah, saving our lives.
The pair is grateful to their guardian angel, Kathy's younger sister, Debbie, who passed away from breast cancer in 2012. And to their angel here.
I get emotional talking about Dr. Nye because, you know, we just always felt like she was like looking after me like I was her own sister or daughter. Prior to COVID, we would hug every time, you know, I would go in for an appointment or our surgeon. And I mean, they just went above and beyond. They are an extension of our family and we are indebted to them.
Libby and Kathy tested and confirmed they carry a genetic mutation, making others in their family more susceptible to breast cancer, something Libby says she'll remember and share with future generations.
And we are so glad to have Kathy and Libby joining us this morning. Ladies, I saw you smile, Kathy, when she rang that bell. It like your face lit up. And I think we all got chills because I've got Dr. Nye sitting right here with us as well. She's a medical oncologist at the University of Kansas Cancer Center. So good to see you. What was it like to see their story and see their faces today?
I wasn't prepared for that.
I know. I have to tell you, ladies, I think you mentioned that and got choked up. And Dr. Nye and I looked at each other and I thought, okay, don't lose it right here. Okay, just wait a second. So we're just so glad that you're both with us today. And I just want you to tell us a little bit about what was it like when you heard the news that you had cancer?
Well, for me, it was very shocking. Being so young, even though I knew this was in our family and I was in the preventative program, it still didn't seem like a feasible thing at 32. So it's definitely
shocking and overwhelming, and not something you're ever prepared for.
And Kathy, I'm sure it was not easy for you to hear that your daughter had cancer. What was that experience like for you?
Honestly, it was probably the worst day of my life. Having gone through it, it's so hard. And to hear that your daughter has it at age 32 is shocking. And it was the worst day of my life.
I can imagine. How are you both doing today? I know our audience wants to know how you're both doing. Tell us.
I personally am doing absolutely fine. My breast cancer this time around was caught again very early because of the program at KU. I did not have to go through any chemo or radiation. I had a double mastectomy, and I feel like I'm absolutely fine.
Libby?
Yeah, I'm doing well too. I mean, it's been a little bit of a longer road. I did the chemo, and then ever since I've been on an anti-hormone regimen. So that provides its own set of challenges. But for the most part, I feel pretty good and pretty normal. So
we love hearing that. And I think you both just answered my question. But Kathy, you enrolled in that survivorship program at the Cancer Center. Libby, you were part of that high-risk program. This clearly played a huge part in your outcomes.
That is so true. My sister who passed from her breast cancer, she was a patient of Dr. Carol Fabian's, and that's how all this started. And she, she's our angel. She's the reason why we had those genetic tests and found out that we are a carrier, not of the BRCA1 or 2. It is a different gene that we've inherited. And thank goodness we were at KU Med, honestly.
And I want to bring in your other angel here on Earth, Dr. Nye, because Kathy just mentioned the BRCA gene, which I think we're all familiar with, at least hearing it, if we don't know exactly what that is. But both tested positive for the ATM gene. Dr. Nye, what does that mean when you test positive for this gene?
So ATM is another breast cancer gene. Like Kathy alluded to, there is more than just BRCA in terms of hereditary breast cancer genes. There's a handful of genes that can increase a woman's risk for breast cancer. And up until just less than a decade ago, we were only testing for BRCA1 and 2. So when Kathy was initially diagnosed, we weren't even testing for the ATM gene at that time. And only because of additional testing were we able to diagnose that that gene is in their family, and therefore Libby was eligible for testing.
So ATM, BRCA, there's a third one, PALB2.
We call that PALB2.
PALB2.
And that's been in the media lately because there was a story written about it. But it is another breast cancer gene. It has a high risk of breast cancer similar to BRCA1 and 2, and it's just not well known in the community that that's another gene that you should be tested for.
And yeah, that is the first I had heard of it, and possibly our viewing audience as well. I bring up a story from years ago when Angelina Jolie did the drastic measures of having a double mastectomy. She had her ovaries removed because she found out that her mother, who also died of BRCA, of cancer, but had the BRCA. You're telling me that not all of these mutations would require that type of drastic prevention, that their early detection is really the key with this.
Correct. So that Angelina Jolie effect was big, and a lot of women showed up and wanted to know if they should get a risk-reducing mastectomy.
And you said they still ask you about that today.
Very common, very common. And of course, I mean, as Libby and Kathy experienced, breast cancer is terrifying. And if some women find out they could just remove their breast and lower the risk, they're ready to sign up. But it is a very big surgery, and it actually does not have a survival advantage for most women. So for most of these other gene mutations, it's not going to make them live longer by reducing the risk of breast cancer.
And it doesn't 100% mean you are free of the
100%.
risk of getting breast cancer. Why is that? You think no breast, no breast cancer, but that's not the case.
Because every single breast cell can't possibly be removed. And there's a lot of other things women can do to reduce their risk of breast cancer. So there's lifestyle modifications as well as medications that women can take, similar to the anti-hormone therapy that Libby was referring to, that can reduce their risk of breast cancer while still keeping their breasts.
Okay, so I want to ask both of our ladies, Kathy and Libby, so what type of lifestyle changes did you make during your treatment and maybe that you're doing now post-treatment?
I guess because we can attribute my breast cancer for the most part to this genetic, the genetic mutation that I inherited. I was leading a pretty healthy lifestyle before. So, that's not to say I was forced to change some things just because of like limitations with surgery and side effects from medicine. But I really was leading a pretty healthy lifestyle before, exercising, running 4 or 5 days a week, like eating well. So I don't know if this is the right answer, but I really haven't changed my lifestyle all that much since my diagnosis.
I feel like it definitely, at this time around, my first time around, I was 42 and I had a house full of little kids and that was crazy. But this time around, I feel like I paid more attention to exercising more, eating better, lessening my alcohol intake, all those things that I should be doing anyway, I paid more attention.
Yeah, it probably just makes you feel good anyway. Dr. Nye, I want to ask you, we talk about the survivorship and high-risk program. How do these specialty programs impact patients? I mean, we see the proof right here with us this morning, but just tell us a little bit about how that's catching that early.
Yeah, I think Libby and Kathy are well versed in all of those lifestyle modifications, and they do a really good job of adhering to those. And they don't prevent breast cancer, just like you said. You can do all the right things and still get breast cancer, but you are leading a very healthy lifestyle and rattling off all the things that have been proven to reduce the risk of breast cancer. But in those programs is where we look at your family history. We determine if you need update genetic testing to find mutations like ATM. We do early screening, mammogram screening, breast MRI screening that leads to early detection of cancers, meaning cancers in an early stage where they're much more likely curable, and hopefully putting less women through chemotherapy and some of those more toxic treatments. And we keep them close. We keep an eye on them. We make sure if there's new information or data coming out that they're the first to know.
So tell us, how does someone know they need to go in for this testing? If just a mother had breast cancer, didn't know if they had the gene mutation, the mother or grandmother or aunt, how did they know that they need to come in and get that testing done?
So if you have a family history of breast cancer or a personal history of breast cancer that was at a relatively young age, typically under the age of 50, or your mother, grandmother, aunt was under the age of 50 at diagnosis, or you have multiple family members on the same side of the family with breast or ovarian cancer, you should talk to your doctor or see a genetic counselor about genetic testing.
So it's not just enough to get that yearly mammogram. You do need to take it a step further and get the testing.
Correct. And even if you test negative for a gene mutation that's associated with breast cancer, you may still be at risk for breast cancer based on your family history.
And that's what you mentioned also about Kathy, correct? You said that she had originally was tested for BRCA, but then came back when she was in the survivorship program. Is that correct?
Correct.
And that's when ATM was discovered.
Correct.
Okay.
Correct. But even if Kathy had tested negative, Libby would have still been at an increased risk of breast cancer because her mom had a family history of breast cancer.
All right. So let's talk about men. It's rare, more rare, but it happens. Tell me a little bit about that. Less than 1% of all breast cancers occur in men, but they do. In 2021, about 2,600 men are expected to be diagnosed with this disease, an estimated 530 men expected to die from it. What should men be looking for if they have a mother or an aunt or a sister or a grandmother with breast cancer? What do? Do they come in and get tested?
So I think the most important thing is for men to realize they have breast tissue. And so men can develop breast cancer, and sometimes we don't like to admit it, but men are still eligible if they feel a mass in their breast to go get a mammogram.
And there's these mutations, though, can cause cancer in other areas for men.
Correct. So BRCA2 increases the risk of breast cancer in males, but a lot of these mutations increase the risk of prostate cancer, pancreatic cancer, skin cancer, so cancers that can also affect men.
Okay, I want you to reiterate that because there are men watching, so they need to listen up. If they've had any female in their history and their family that has had breast cancer of any kind, they need to be checked.
If it was at a young age,
okay,
then they should talk to that woman about if she's had genetic testing, and if they're unable to get testing, that male may still be eligible for genetic testing for himself. And if there is someone in their family with a genetic mutation, the men in the family should also still be tested for that mutation.
Okay, so I have a question then, Kathy and Libby. Any men in your family that would be at risk?
I have two sons. We have two sons, and they have not been tested. I also have another daughter, Libby's younger sister. She was tested, and she did not have the genetic gene. I have another sister, my sister Kim, and she has the gene, and she chose to no breast cancer, but she chose to have a double mastectomy.
Okay, lots of choices there. So the daughter, you said you had another daughter that was tested and did not have the gene, but you said is she still at risk or and still needs to get her mammogram?
So she still would be eligible for high-risk screening, especially given Libby's young age at diagnosis. And so we would still keep a close eye on her as well and make sure she's getting all the appropriate screening she needs even without the mutation.
Okay, we are going to get to our Facebook and YouTube viewers with some community questions as they're coming in. Mark wants to know, if a man gets breast cancer, does that mean their sons are more at risk?
So that's a great question. The risk of breast cancer in males is very low, although still there. And so if that male gets genetic testing and has a BRCA2 or another breast cancer gene, yes, his sons may be at a higher risk of male breast cancer, but having a father with breast cancer as a son may not significantly increase that risk of breast cancer for the son. Okay. There's no mutation.
But a daughter would also be at risk.
Correct.
Correct. Okay. Here come all the questions. Okay, so Yana wants to know, if you have twins, is it possible for one twin to carry the gene and not the other twin?
That depends on if they're identical or not identical.
Oh, okay. So if they're identical?
Most likely. And there's a 50% chance that it would have been passed down.
Okay. Jen wants to know, can men have mastectomies or the removal of breast tissue?
Yes, they typically don't do it prophylactically or in a risk-reducing setting, but for the treatment of breast cancer, yes.
Okay. All right. So Mary Kay wants to know, she says, we've been reading this for years. I hope it's true. I've been reading that a glass of wine every night is good for your health, but now I'm hearing alcohol could be bad for you. What's the deal with this? Why the back and forthing? People say it's good for the heart, it's good for the body. Give me some good news, Dr. Nye.
I'm sorry. I'm going to burst your bubble. So alcohol is associated with an increased risk of breast cancer. The more alcohol you drink, the greater the risk of breast cancer. And we recommend limiting it to ideally less than 3 drinks a week, no more than 7 drinks a week. But again, any additional alcohol increases your risk of breast cancer.
Okay, I'm glad you said that. I don't think everyone knew that. Am I the only one who didn't know that? Because I know Kathy said that she reduced her alcohol, probably because she heard that from you.
She listened so well, yes.
She is a good patient. But again, I think when I'm drinking that glass of wine, I'm thinking, I'm doing so good for my heart, but I could also be putting myself at higher risk of cancer. Okay, that note is well
Everything
taken.
in moderation.
Everything in moderation. Okay. Okay, what is the best thing to eat? Well, Janet wants to know what's the best thing to drink to decrease risk in breast cancer. And I'm going to say, what are some good foods? Let's do food. Water. Yeah, water. Yummy water.
So the nutrition question is a more difficult one to answer living in the Western world and eating a Western diet. But we think it's going to be more like a Mediterranean style diet, high in fruits, vegetables, legumes, low in red meat, processed food. But again, everything in moderation.
I think we all knew that, but it's nice to hear you say it. And we can't escape it. Okay, Christy says, I'm curious to know if 2 of my dad's sisters, so her 2 aunts, had breast cancer in their 60s. What are my odds? No one has ever talked to me about this.
So in the high-risk breast clinic, what we would do for an individual like that is we would run a personalized risk assessment. So we look at the individual's personal risk factors as well as that family history and calculate their lifetime risk of breast cancer. They may or may not be eligible for genetic testing based on their other family history, but they may still warrant high-risk screening like an annual mammogram and or breast MRI.
Okay, because I would imagine when Christy went to get her mammogram, they always ask, has anybody in your history, has anybody in your family had breast cancer? So they'll ask, they'll make the assessment and then decide. So, but do you think that would seem like that would be a higher risk? 2 aunts?
2 aunts, again, it depends. For someone who had their first child at a very young age, that reduces their risk of breast cancer or went through early menopause. So it really depends on, everybody has a very individualized risk of breast cancer.
Okay, but just ask questions, right?
Ask questions. That should prompt the question of what is my risk of breast cancer.
Joe wants to know, do you know if insurance typically covers gene testing to see if you are at risk of breast cancer? Her mother survived breast cancer. Good to hear.
Genetic testing has come a long way, and it's much more financially feasible than it used to be. If you meet criteria for genetic testing, most insurers, including Medicare and Medicaid, will cover genetic testing, and the out-of-pocket should be either nothing or less than a few $100s these days.
And well worth it?
And well worth it.
Melanie wants to know, if a woman is diagnosed in their mid-70s with DCIS, stage 0, is stage 0
Correct.
a stage?
It is.
Okay.
Yep.
You'll have to tell us what DCIS is. Do their daughters carry a higher risk of breast cancer?
So DCIS is ductal carcinoma in situ, or non-invasive breast cancer. And yes, it still counts as a breast cancer, and their daughters may be at an increased risk of breast cancer. The older a woman is when they're diagnosed with breast cancer, may have a less of a risk on their offspring's risk of breast cancer, but having a mom with breast cancer can almost double a woman's risk of breast cancer.
Okay. Isaac asks, do all cancers impact immune function the same? If not, what is the impact of breast cancer versus multiple myeloma that affected Colin Powell, for example? I had not heard that. So do you know much about that difference?
Yes. So solid tumors, we're learning a lot about the immune system in cancer in general. Multiple myeloma would be different, though, in terms of how it affected the immune system. But solid tumors likely interact with the immune system, and then our treatment of tumors with chemotherapy impact the immune system. But multiple myeloma itself would have a different impact, a more detrimental impact on the immune system.
All right, Dr. Hawkinson, you're up. Linda wants to know, all through this pandemic, we've heard that those with diabetes are at high risk. However, when the booster shot came out, it was not at the top of the list for qualifications to get the booster. Can you explain that?
Yeah, I can't explain exactly why it's not up there, but certainly we would put those people at higher risk. Those people at higher risk of severe disease do include obesity, diabetes, heart disease, lung disease. So it is pretty broad. I can't explain exactly why it's not high on the list, but it should be in there, and we would certainly recommend it.
Okay, so somebody with diabetes could and should go get their booster now?
I would say, yeah.
Talk to your doctor?
Yeah, we have seen just too many people with diabetes with that comorbidity in the hospital with. So I would talk to your physician about it. I think it would be safe and advised to go get that.
All right, Jennifer also has a question for you. Is the slight number uptick just a fluke or an indicator of something else? Is it just too early to know?
Yeah, it's too early to know. We have seen that kind of wobble between 15 and 20. I think last week at one point we were down to 13. So I think really the best thing is to watch over 7 days or 10 days and see what's going on. Hopefully in the next day or so we'll see these numbers decrease. But that is why we look at that rolling 7-day average or rolling 10-day average. As far as I know, the number of cases in the Kansas City area has continued on that rolling 7-day average downtrend of total cases. So we're just hoping and believing that here at the health system that is true as well. And again, I don't know what we are doing right now for transfers. We could have some of those people transferred in from other places as well. So it may not just be indicative of our true number of cases and hospitalizations here in the metro area, because we do get transfer calls on a daily basis as well.
Hey, Libby and Kathy, Tell us, how have you navigated through this pandemic? Tell us a little bit about what that experience has been like for you.
Luckily, I was done. I had finished my last round of chemo in January of 2020. So, prior to COVID. So, by the time COVID hit, I mean, we, obviously took extra precaution because of our situation, but kind of just like everybody else in that regard, and got vaccinated as soon as we were eligible. And I would have to go into KU every month for a monthly injection, and so just continuing to be safe while in public. And yeah, agree.
About the same. Dr. Nye, yeah, what advice do you have for people who have come out of treatment? We're in the middle of a pandemic, on the tail end, and people try to get vaccinated. What are your thoughts, and just what is your advice to them to stay safe and healthy?
So for a lot of patients that were receiving chemotherapy during the pandemic, and when the vaccines became available, they were eligible for a booster, or if they have active cancer or are undergoing chemotherapy, they're also eligible for a booster. So they should talk to their doctor about the booster vaccine.
So should Libby and Kathy get boosters, be able to get boosters?
So that's a great question. They were not undergoing chemotherapy at the time of getting their vaccine. So hopefully they've had a great response, but everybody I think should stay tuned to Dr. Hawkinson as to when and where and why we should get our boosters. I'll sign up.
Okay, so Bridget has a question for both doctors here. So I'm caring for my mom who is fighting stage 3 ovarian cancer at age 77. She did genetic testing and it was negative. Should my daughter and I also undergo genetic testing?
Great question. So what the question would be, did mom have testing for just BRCA1 and 2, or did she have a panel of tests? So similar to breast cancer, there are other ovarian cancer genes beyond BRCA1 and 2. If mom had complete testing and there's no other family history, then the daughter and granddaughter may not need additional genetic testing at that time.
Okay, Dr. Hawkinson, also she had both her COVID shots and her booster 2 weeks after one of her chemo treatments. Would you recommend the flu shot, and what is the best timing in between her chemo treatments?
Yeah, I would definitely talk with your oncologist about the best timing. They really know the best dynamics of... Sorry. Yeah, I would talk about, talk with your oncologist about the best timing of the vaccinations. They would know the best chemotherapy dynamics on when you are going to have that optimal immune system to react to the influenza vaccine, either at the end of your chemotherapy cycle or just prior to it. So certainly talk with your oncologist. And if you are able to get the booster, you probably will be getting the influenza vaccine around that same time in your chemotherapy cycle. But the best thing to do is talk with your oncologist.
Dr. Dye, Joe wants to know, what about an adoption situation? You don't know the family history. How do you know what those steps should be?
So in our national guidelines for genetic testing, it does include lack of knowledge of family history, including adoption. So you could talk to your doctor or a genetic counselor about still pursuing genetic testing in that scenario.
Okay. Talk about just the sleep play. What kind of part does sleep play in cancer reduction? I know it goes along with just really good health.
There's a lot of ongoing investigation in that area. People are studying sleep and circadian rhythm and how that affects both obesity as well as cancer risk. I think we don't have the answers yet, but definitely good sleep is good for our health.
Okay, Isaac wants to know, I got my second Pfizer dose in April. 28 years old, generally healthy, but works in a retail store on the weekends. Should I get my booster, Dr. Hawkinson?
Yeah, I mean, I would say yes, because I think if you are going to be in close contact with the general public, I think that would be a smart thing to do. You would certainly be at risk of exposure. We know those essential workers that work at our grocery stores, for instance, have a lot of contact with the public. And unfortunately, again, we have to assume that not everybody who is eligible for vaccination has gotten it. And there continues to be, a fairly high prevalence of disease around the community. So I think that would be something to certainly think about and just understand other risks as well, especially if you have people close to you who are in some of those high-risk categories, such as with cancers or other issues that would put them at higher risk of possibly going to the hospital or going to the ICU when and if they get the disease. So it's certainly something you should consider.
Dr. Nye, what are you seeing as far as your patients right now with, I know you said back in the spring you were starting to see people start to come back and they were being diagnosed with cancer because maybe they missed their screenings. Tell us what you're seeing now.
So back in the spring, yes, I felt like people were getting vaccinated and then felt comfortable coming back, even though we'd been encouraging them to get their screening mammograms all along, and we saw some later stage diagnoses of breast cancer. And now we're still seeing kind of breast cancer diagnosed at all stages. Right now, a lot of people are getting back to getting that mammogram, and breast cancer is being diagnosed. I'm also seeing a really good uptake of vaccination in my oncology clinic, which I'm really proud of those patients for going out and getting their vaccines, and lots of good questions about the booster.
Good. Love to hear it. All right, we're going to get to our final thoughts today. I want to start with Libby and Kathy. First of all, just thank you so much for being with us and sharing your story, and we're just really glad you both are doing so well. What do you want us to know?
I mean, I think we would both just say be your own advocate for your health. Know your body and know your family history, and don't be afraid to take the preventative measures. And we both really feel like knowledge is power. And even if it might be scary to know certain things, it's better to get ahead of it, because, again, I don't think either of us can emphasize enough how early detection really, really saved our lives.
Kathy, your message?
I agree with everything that Libby has said. Our mantra all along has been knowledge is power, and know your body. Don't be afraid.
That's really well said, Dr. Nye. You must agree.
I agree.
What they said.
Yes. And I also, this month, Breast Cancer Awareness Month, I try and treat it as Breast Cancer Action Month. So like they refer to, do something this month. Collect your family history, write it down, share it, ask about genetic testing in your relatives, go get your mammogram, but take an action this month for your own health.
I love that. Put it top of mind. Dr. Nye, thank you so much. Dr. Hawkinson, final thoughts today.
Yeah, there is a good list of certain medical conditions for those people that are high risk of hospitalization and severe disease on the CDC COVID-19 website, especially under the boosters and learn more. And there is just a large list. Again, it is pretty broad. That does include diabetes mellitus as well. And remember, we will continue to keep you updated on the latest recommendations. We know that from the headline, the FDA will be okaying that mixed dosing, and we do have a picture to show kind of what is going on. Now, just because they okay it, they still stress that you should still stick with the same vaccine that you originally got. And what this image shows, and this is from the science journal Nature, published in July of this year. And on the top there, you can see that there is the mRNA vaccine particles. On the bottom there, on the far left, there is the adenovirus vaccine particles. Again, that's the Johnson & Johnson or AstraZeneca. And then what happens is on the top, we see that there is a large induction of antibodies. Below that, with the adenovirus, we see that there is a possibly larger or more robust immune response of the of the T cells, the CD4 and CD8 cells. All that combines, though, to create an immune reaction. So right now, it seems like both are going to be okayed, but the formal guidance continues to be you should really stick with the vaccine platform that you got. However, their main question they're answering is, what about those people that just got that single dose of Johnson & Johnson? Should they do another dose of Johnson & Johnson or one of the mRNA vaccines? They said that they would okay it, but again, the guidance continues to be right now, stick with what you originally got, but we'll wait for their final formal guidance to come out once they meet.
Thanks for that. I like that graphic you showed. That was a good one. I do have one last question. Since I have Dr. Nye sitting right here, I have to ask this question for Fanny. She is of Jewish descent. Her sister had triple negative 2 years ago. Brother, colon cancer, passed away to metastatic to lungs. Dad died of lymphoma. Mom turning 100 with no cancer. What's her probability? She's turning 65 next week.
So it was a sister that had breast cancer?
Yes, sister had
negative.
triple negative 2 years ago.
So having a sister with triple negative breast cancer, having a sister with breast cancer already doubled your risk of breast cancer, but having Ashkenazi Jewish descent and somebody with triple negative breast cancer increases the risk of a BRCA mutation, so genetic testing would be recommended.
So Ashkenazi, is that specific or anybody of Jewish descent?
The majority of individuals living in the U.S. of Jewish descent will be Ashkenazi Jewish descent, and there is a 1 in 40 risk of a BRCA mutation in Ashkenazi Jewish ancestry compared to 1 in 400 in the general public.
All right, Fanny, thank you for asking that question. We've gotten that one before. Dr. Nye, thank you for that, and thank you for being with us today. Tomorrow it is Open Mics with Dr. Stites. So imagine you beat COVID-19, but there are still lingering health effects months later. We're going to hear from one COVID long hauler and how it's impacting her life with her children.
I knew I had COVID, but I didn't know why I was having all of these symptoms.
From numbness in her hands and feet to dizzy spells requiring her to rely on a wheelchair. What exactly is causing all this and the treatments available? We're going to tell you more about it. Thanks so much for joining us today. Don't forget you can watch us anytime on Facebook and YouTube. We'll see you tomorrow at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.